As healthcare professionals, we hear headache complaints practically every single day. But migraine, well, migraine is so much more than just a bad headache. It's a wildly complex primary neuronal dysfunction that can absolutely paralyze our patients' lives. So, what if you could trace the exact neurovascular cascade of a condition that affects just a massive chunk of your patient panel? Let's dive into this explainer and crack open the clinical mystery of migraines.
17.5%. That striking number right there is the lifetime prevalence of migraines in females, compared to 8.6% in males. We're talking about nearly 1 in 5 of your female patients. It really highlights the massive epidemiological burden we're dealing with in clinics and EDs all the time. Interestingly, before puberty, it's pretty much a level playing field. But once adolescence hits, boom, we see this sharp divergence, with cases peaking right in those crucial 20s and 30s during prime working years.
So, welcome colleagues. Today we're breaking down the modern, evidence-based approach to migraine diagnosis, pathophysiology, and management. We're going to treat this like a real-world clinical teaching session. We'll be tossing out those outdated concepts to give you the actual practical tools you need for your day-to-day practice. Here's our quick clinical roadmap. Mechanisms in epidemiology, diagnosis and red flags, acute management, preventative therapies, and finally, estrogen-associated migraines. Let's get right to it. First up, mechanisms and epidemiology. Let's talk pathophysiology. For decades, we really leaned on the vascular theory, right? The idea that simple vasodilatation was the main culprit. Well, scratch that. We now know vasodilation is just an epiphenomenon. The modern paradigm actually starts with cortical spreading depression. It's this self-propagating wave of neuronal and glial depolarization. And sure, this wave triggers the classic aura, but more importantly, it activates the trigeminal-vascular system. That activation drives a massive release of vasoactive neuropeptides, sparking sterile inflammation and just profound pain sensitization in the meninges. And among all those neuropeptides, CGRP is literally the star of the modern migraine model. It's an incredibly potent vasodilator, and the key mediator transmitting pain from the intracranial vessels straight into the central nervous system. Honestly, truly understanding CGRP is vital for your practice today, because as we'll see in a minute, it's the primary target of our absolute best breakthrough therapies. Okay, Section 2, Diagnosis and Red Flags. How do we spot this in the wild? Let's apply this to a real-world case. Imagine a 32-year-old female patient walks into your ED. She's got severe, throbbing head pain, profound nausea, and she can't stand the lights. To quickly figure out if this is a classic migraine attack, just deploy the POUND mnemonic. It's super practical. P for pulsatile quality, O for one-day duration, usually 4 to 72 hours, U for unilateral location, N for nausea or vomiting, and D for disabling intensity. If she's checking these boxes, you very likely found your diagnosis. But to be totally clinically precise, we really need to use the ICHD-3 criteria. This strictly separates attacks with fully reversible focal neurological auras from those without. For migraine without aura, you actually need a history of at least 5 lifetime attacks for a formal diagnosis. Migraine with aura, you only need 2. And those auras are characterized by visual, sensory, or speech symptoms that gradually spread over about 5 minutes and last up to an hour before the actual headache hits. Now, beyond those standard presentations, you absolutely must be ready to classify some of the more complex subtypes. For instance, chronic migraine means the patient is suffering 15 or more headache days a month. Vestibular migraine, that presents with episodic vertigo. Migraine with brainstem aura brings in scary stuff like diplopia or ataxia. And hemiplegic migraine is absolutely critical to recognize because the aura literally includes motor weakness. These subtypes totally change the clinical picture. While migraine is fundamentally a clinical diagnosis, you've got to watch out for the red flags. These are your absolute line in the sand. If you see unexplained neurological deficits or an abrupt, thunderclap onset, that demands immediate neuroimaging, no questions asked. You have to rule out secondary causes like hemorrhages or intracranial masses. Moving on to Section 3, Acute Management, getting those symptoms under control fast. So, with secondary causes ruled out for our 32-year-old patient, we need to completely separate our treatment goals. Acute management is all about aborting her attack right then and there in the ED. Preventative management, which we'll jump into next, is the long-term shield we're going to set up to stop these headaches before they even start. We generally use an algorithmic approach for acute care, scaling our intervention based purely on severity. Mild to moderate, simple NSAIDs like naproxen are your best first line.
But for moderate to severe attacks, you've got to step it up to migraine-specific agents like triptans or the newer CGRP antagonists we call gepants. If nausea is a big issue, skip the oral meds entirely and go for parenteral antiemetics like metoclopramide. And if they're in refractory status migrainosus, that's when you escalate to therapies like dexamethasone. But wait, a massive word of caution here. Triptans and ergoderivatives like DHE actively promote vasoconstriction. They are strictly, and I mean strictly, contraindicated in patients with cardiovascular risks, uncontrolled hypertension, or hemiplegic migraines. Missing this can quite literally lead to catastrophic ischemic events, so screen your patients carefully.
Section 4. Preventive therapies. Setting up that long-term prophylaxis. When your patient is dealing with 4 or more debilitating headache days a month, relying just on acute meds is super risky because of medication-overuse headaches. So choosing a first-line preventative, it's really an art form. You want to match the drug to the patient's existing comorbidities. If they have hypertension, beta blockers like propranolol give you a 2-for-1 benefit. Dealing with depression or insomnia, amitriptyline is a great choice. Topiramate works nicely if obesity is a concern. And for those who fail the oral options, those new CGRP monoclonal antibodies are an absolute game changer with incredible targeted efficacy. And hey, let's not ignore the non-pharmacologic stuff. For patients who really want to avoid systemic drugs, or maybe pregnant patients where our pharmacy options are super limited, non-invasive cranioneuromodulation devices are fantastic. Things like transcutaneous supraorbital nerve stimulation provide solid, evidence-based relief without the systemic side effects. But here is the major reality check you have to pass on to your patients. Managing expectations is absolutely paramount. You've got to counsel them that these preventative drugs take time. We really can't assess true efficacy until at least 3 months after they hit the target dose. You need to insist they keep a headache diary and explicitly warn them not to pop those acute abortives too often, otherwise they'll end up right back where they started with medication-overuse headaches. Finally, Section 5, estrogen-associated migraines. Let's look at those hormonal triggers. Like we talked about earlier, women are disproportionately affected by migraines, so we absolutely must address hormonal triggers. That steep drop in estrogen right before menstruation acts as a massive catalyst. The ICHD-3 actually defines pure menstrual migraine as happening exclusively within a highly specific 5-day perimenstrual window. That's 2 days before menses onset through 3 days after. If the attacks cluster right there, we can totally change our preventative strategy. For these super predictable attacks, we actually bypass continuous daily medications. Instead, we use something called targeted mini-prophylaxis. By prescribing NSAIDs or long-acting triptans starting just a day or 2 before that expected window and carrying it through the cycle, we can brilliantly blunt the hormonal trigger while keeping the patient's overall medication load really low. Well, we've covered a lot ground today, from modern pathophysiology and diagnosis to acute protocols and tailored preventative strategies. As you take these evidence-based tools back to your practice, I want to leave you with a thought. As these CGRP-targeted therapies continue to absolutely revolutionize our clinical algorithms by attacking neurogenic inflammation at its source, just think about how fast this field is moving. How close do you think we are to completely silencing the hyperexcitable brain? Thanks so much for joining me for this explainer, and I really hope this gives you a practical edge in your daily clinical practice.